during my third year of medical school clerkship, I decided family medicine was the right career for me. I particularly like the breadth of the scope, the continuity of getting to know my patients, and the close connections with them. But I was won over to rural family practice in my fourth year of medical school by an amazing 1 month rural family medicine placement in Lucknow, Ontario. It was the practice of Doctors Mel Corin and Jack McKim. And I learned that family medicine in a town, well, I had grown up in cities, so I really didn't have any experience with smaller places. But I learned in that elective that in a town, especially when it had access to a rural hospital, it not only involved those basics that I wanted, the breadth of scope and the continuity and close relationship to patients, but it also offered so many more things. One could, again, the even broader scope of practice, including working in the emergency department, inpatient care, intrapartum care. And I was also excited about the connection to the community and the opportunity to make a real difference on the community level. But it was rather daunting to consider where to set up practice because 45 years ago, it wasn't so easy to move locations. There were no clinics or other infrastructure. We ended up having to buy a big old turn of the century house, convert it into an office on the main floor, and we ended up living upstairs in an apartment above the office until we could get our own home a few years later. So it was a pretty daunting decision, but it was made easier when we stopped and thought about it as a 5-year commitment rather than where will we be for the rest of our life. And Goderich turned out to be an absolutely wonderful place to practice medicine. For the first 25 years of practice, we were there. So 5 turned into 25, and it was a wonderful place to raise our 3 children. But you asked what the most important factor probably to our choice was the presence of like-minded, generous, and collaborative colleagues. That was the most important thing about it. I'll probably share 2. I'll share one that was a sad moment, had an impact, and one that was a happy one and had a different kind of impact. So I'll start with the sad one. While I was a medical student, my particular preceptor was away, and I went into the hospital to sort of look at the patients we'd been seeing that day, and then I was going to head off for the weekend. And I was told that they had just called off a resuscitation in the emergency department. And so I went into that room, and things were over. There was nothing that could be done then, but it had been a 3-year-old or 4-year-old child that had been admitted to the hospital the night before with croup. And that morning had been taken out of the croupette and laying back down in the croupette and then arrested. The child wasn't able to be resuscitated. As soon as I walked into the room and heard what the situation was, I immediately thought of epiglottitis. And indeed, that was what it turned out to have been. This was before the days of Haemophilus influenza vaccines. And what had been needed, people had tried the usual types of resuscitation with bag and mask, but because of the epiglottis and the airway obstruction, they couldn't get any air in. And I often wondered, I guess, well, there were several things that came from that. One was I had often wondered if I'd been called earlier, if that child's life could have been changed, because I recognized right away, even though I was a medical student, this was epiglottitis. That child needed either a trach or large bore needles placed. So I realized two lessons from that. One was the importance of excellence in clinical care. And when I did set up practice in Goderich, I implemented, or the group of us, I guess I would say, implemented a whole protocol for the management of croup in our emergency department, with using a croup scoring system and how things needed to be handled, including making sure the physician was called and that sort of thing. The other lesson I learned from that case was the unfairness of illness, because I had been going in to the hospital to make rounds on an elderly patient in the long-term care ward that was quite demented, and I had had a discussion with, and this patient had developed a fever and a cough and probably had pneumonia, and it had quite an interesting discussion about what decision you make with how far you provide care. And the family had been keen on oral antibiotics, not intravenous, and no heroic measures. Anyway, after this very upsetting time in the emergency department, I went upstairs. We had seen this elderly person started an antibiotic the night before by mouth, and I went up to see them, and their fever had settled, and they were much improved clinically. And to me, that I carried that with me, that yes, there are a lot of things that are unfair with illness. So I'll go to a happier story, and something that made quite an impact on me early in practice. And this has to do with the kindness and generosity and humbleness of being a medical practitioner and colleagues, and your colleagues. So when we set up practice in Goderich, my husband Jim and myself, if people don't know, I am married to Jim Rourke, who is one of the godfathers of rural medicine in Canada. But anyway, when we set up practice in Goderich, they definitely needed both of us there. They were very short. And one of our colleagues, even though we had our own office, everybody had their own little office, no more than two people in an office, called us and said, there's no point, the day you open your office, don't worry about hiring your staff to sit there to answer the phone before you're open. Drop an appointment book around, tell us how you want to book it. And so that doctor in their office made sure we were seeing patients right from the start. And the other thing was, one of my very first patients in labor, I was a little uncomfortable with how things were going. There was no such thing as temporary privileges in those days. You got your privileges and you were it, right from the word go. And so one of my first interpartum cases, I was a little uncomfortable, and I called one of the doctors, the doctor that was the most recent in practice, had been there for 5 years, and he and one of his classmates had set up practice together. And I called him and said, David, would you mind coming in and doing a consult? For obstetrics in Goderich intrapartum care, we did not have any surgeon, or we did not have any obstetricians. We had general surgeons that were good technicians for cesarean sections. But if you needed a cesarean section, you consulted one of the other family docs. So I called my colleague and explained that, I thought this was a little bit high risk, and would he come in and do a consult for me? And he said, you don't have to make a case at all, Leslie. He says, when Bruce and I went into practice, we considered every person that we were involved with their delivery to be high risk because it was us. So we called each other in for every case for the first at least 6 to 12 months. And that was a wonderful lesson. That was a lesson in being humble, in not being afraid to ask for help, and in knowing the importance of collegiality of your colleagues. So I would think my choice wasn't so much to become a leader per se, but rather to share my passions and my skills. So my interests and passions in making sure for clinical excellence, advocating within the community and broader lifestyle issues, reflecting on lifestyle issues, and my networking and organizing skills. So those themes have been my drivers, I would say, and there's examples of every one of those in, I guess, the things that other people would identify in things that I've been a leader for. So I don't know if you want any examples of those, but I can give some. Um, so as far as developing and sharing improvements in family practice, probably the biggest example of that would be my work in the Rourke Baby Record. It was very easy, actually, to be a leader in rural practice. And so I was involved with, I set up a bicycle helmet safety program, and then ultimately turned a cycling tragedy later into an opportunity to prevent similar tragedies through advocating for legislation. As far as lifestyle issues and reflecting on boundaries, did a number of workshops, publications, networking about personal professional boundaries in rural practice, and organizational abilities. Probably my best example of that one would be when I was doing my Master of Clinical Science in Family Medicine degree at Schulich School of Medicine, which was called at Western, then in the late 90s. Jim and I realized together that the format that this master's program had moved to was a blended format with a long weekend. Well, it was 2 weeks, but for our one course that we developed, a long weekend followed by asynchronous distance learning. This was before the age of internet and all that. So, but what we had the idea, but then I took with it and ran and did all the organizational things and ran it, was a course called Rural Medicine and Health, which ran for 5 years between the years 2000 and 2004. And it brought together over those 5 years more than 50 learners and facilitators. And that ultimately built a network of current and bred future leaders in rural medicine in Canada. And so that's been very wonderful to see the significant leadership roles in rural medicine with respect to teaching and research and program development and advocacy that came from the people who participated in that. And then throughout, I guess part of it is the desire to share what one's done. So, like drew up this chart in our practice for well baby care. By the way, we also drew one up for prenatal care, which ended up, because there was no Ontario provincial prenatal records, which was the basis for the first one in BC. We had flow sheets for diabetes, stickers for smokers, hypertension on our charts, anything to make it run more efficiently and be able to be excellence in care. So, as well as wanting to share those things, then there was practice-based research that writing papers so that these things could be shared more widely. So, I guess those would be the ways you'd say that I've been a leader. I found it very easy in Goderich to be a healthcare leader. A small community really expects its professionals to be community leaders. So we had an amazing group of medical colleagues, and most were leaders in something in the community. One became a national leader in environmental health. Several became quite involved with medical politics. And others were very involved with community projects, saving a rail bridge, developing a big recreation center. So it's one of those things that I think there's less of a boundary about. You live with the people in the community, and so being a leader is pretty much easy to do. The biggest challenge, of course, which wouldn't be surprising, was work-life balance and the whole personal professional boundaries issues in a small community. Sometimes well and sometimes not so well. So I wouldn't say I'm an expert, but I certainly have had lots of practice because there's been a lot of years. So when I was pondering this thing, a couple of things. One was balance doesn't just happen. It takes awareness and planning and setting priorities. One thing I did was I got help for those things that were most annoying if they were left undone and which I didn't enjoy. So, for example, I was able to get someone to do housekeeping for both of us because when we had extra time, we really didn't feel like spending it cleaning our house. But if you love to clean your house and it's a way it relieves your stress, well, obviously, don't hire that out. Having I've talked about my colleagues before, but having colleagues that you could share things with and share time with was a big help too. But also it has to be a balance of seizing the moment. There has to be moderation. There has to be flexibility. Medicine is not a 9-to-5 job. It's a calling. And there will be times that it will interfere with your personal life. But so I always liked the analogy that a wonderful author named Barbara Coloroso, who writes about child discipline. She wrote her first book was called Discipline, Kids Are Worth It. And she talked about three styles of parenting. One was the brick wall where everything was yes or no. And the other opposite extreme was the jellyfish where there was no structure at all. But the one in the middle, she used the analogy of a backbone that had a structure, but there was some flexibility to it. And I think that works really, really well for balance in practice. That if you're so rigid, you're not going to be happy. The people you work with aren't going to be happy. Your patients aren't going to be happy. Your family's not going to be happy. But if you've got no boundaries, medicine can gobble you up. And so I really like the thought of the backbone with the flexibility. So that was one thing about moderation. The other thing when I was thinking about balance is work-life balance changes at different times in your life. So your life is constantly changing as things go along. So the right balance when our children were young was very different from when they had grown and left home. Um, so so that was something. Then you add a couple of other complexities. One was rural practice. When you're in rural practice, as I said before, most of your patients enrolls other. I could have a patient that was my bank manager, could be one of my kids' teachers, could be the hospital administrator. So you had to learn how to compartmentalize these things and put them into their own little boxes. And you also had to watch that you didn't do it to yourself. So you see somebody in the grocery store that's a patient. What's the common thing that people say? Hi, how are you? Well, that's not the right thing to do when you're seeing a patient, because first of all, they can look a little confused, or they can view it as a wonderful opportunity and take right off into telling you how your most recent treatment worked for them, prescription or what. So had to very consciously learn to say, hi, it's nice to see you, not hi, how are you? So that was one funny little thing that helped. You realize you do that a couple times to yourself, you realize, well, of course you're asking them. So and the other layer of challenge was having our medical marriage. Jim and I both being in practice, we wondered what would happen to our marriage when we were working together all day. And two things. One was we really didn't work together. I mean, we did work together, but I had my offices in the front of the building and Jim had his offices at the back of the building. And OHIP got a really good deal, because if there was something interesting or perplexing, we'd sort of call each other in and sort of say, hey, look at this rash, or listen, that really interesting heart murmur. And so did we do formal consults? Sometimes, but not often. But it was fun to be able to share things. But the other thing we had to watch for was that we weren't talking medicine 24/7, because we wanted our relationship to be, it couldn't just be unidimensional. We wanted it to be more than that. And remember, I said that we bought an old building, we renovated it, the office was on the main floor, we lived upstairs. So we set up this hokey little thing, little rule, that if it was after hours and we were upstairs, and if one of us had a medical question for the other about a patient, if we got a call or something for a case for the day or something that was going to happen the next day, we go, oh, and we go downstairs through the door into the office and consciously discuss it then. And that was a really, I think, important thing to do, so that we ended up, our time away from medicine was away from medicine with the two of us. Now, 3-4 years later, when we had children and we were living in a different house, we obviously didn't leave them and go across town and go back to our office. But we had to discuss things. But by that time, we'd set it up as a conscious decision. Is this something that needs discussed tonight? Or is it something that can wait till we're in the medical situation? I didn't have a lot of barriers, to be honest, because we had excellent colleagues, and my husband and I decided that we would split our roles according to our passions and once we had children, according to our passions and our real interests. And although I really enjoyed interpartum care and the emergency department, he was far more energized by those things than I was, and I really enjoyed seeing my patients in clinic and my organizational skills. So I didn't do as much of those hospital-based activities, but that was a conscious decision. I shouldn't say that. I looked after my in-hospital patients, but as far as doing intrapartum care and emergency shifts, that was something I was glad to cut back on, and he was glad to pick up more of. So the balance was a balance that was helped by individual thinking, by our partnership, and by our colleagues. So yeah, we were lucky in those days. We had enough physicians. We were able to get locums when we wanted to go away. So a lot of the barriers that are really difficult now for people didn't really exist, or to a lesser extent. Well, there were, I can think of patients. I can think of a couple of patients, elderly gentlemen, one quite, but you win them over. One that was housebound, blind and deaf. His wife was a patient of mine, and she asked if I'd come make a house call on him and take him on. And so I went out to see him, and he quite firmly made it known that women should not be doctors. So the first thing I did was I looked in his ears, and they were absolutely full of wax. And so came back and syringed them out, and he could hear again. This woman doctor wasn't so bad after all. Then his eyes, he had dense cataracts in both eyes, and he had COPD, a chronic obstructive lung disease, but cataract surgery was improving at this point. He'd been told in the past he could never have them done. So sent him and got one done, and he could see again. So suddenly, being a woman doctor was fine. I also had another elderly gentleman, an old bachelor, who was very sweet to me in the office. But when he was admitted to hospital, now why did he not recognize me? I must have been wearing a mask or something. I don't know. Anyway, when I came in to see him, he thought I was one of the nurses, and he was absolutely nasty until he realized I was his doctor. So, there were times you had to make sure that you gave respect and got respect back. But as far as the other medical professionals, when I was in practice, I don't know. I guess I proved myself. I wasn't overly sensitive. And no, so I don't know. I felt I'd been blessed about the milieu in which I worked. So some of it, the advice I give to young, middle, and late career women in medicine, some of it is what I mentioned earlier about balance and priorities that can change in different life stages. So as I say, depending where you're at in your life cycle, your balance will be different. Remember the basics: eat well, sleep well, physical activity, especially outdoors. And as a leader, remember to help those around you to be successful. Sometimes I have seen some women leaders who seem to feel they had to be as strong or more brick wall than the men in order to prove themselves, instead of leading by kindness. And I think rather than pushing down those that are coming behind you, if you can pull them up and help them succeed, I think that's the sign of a good leader, and advice I would give to women in medicine. I don't think there's much of anything I would change. You never know the opportunities you turn down, what could have happened to them. The one big opportunity that came out of the blue, well, it wasn't totally out of the blue, but it was out of the blue, was when we were approached to consider positions in Newfoundland at Memorial University. And it was, we were happy. We were in practice 25 years. We were doing academic things as well. Jim was involved with a lot with the faculty at Western. And, well, I was faculty as well, but he was full-time in an assistant dean role. But the thought of picking up and starting a whole new career in a whole different province was, and I'm so glad we did it. It turned out to be our great adventure. It not only offered Jim an opportunity to make a huge difference there, but me as well. And it coincided with when our last child went off to university. So as I said, the balance and the empty nest, I became a full-time faculty member, full-time practice teaching administration and research. And that move really was, so again, it was one of those things. If a door opens and you don't go through it, you never know what you would have missed. But it was, so there's very little I would redo. Okay, so I'm just going to talk career-wise here, because I can't consider my kids as accomplishments, but that's probably, my family is who I'm the most proud of. But when you're asking me about career satisfaction, I'm thinking about that one. I think it would be the small moments and the large moments. So the small moments of making a huge difference in an individual's life. I've always felt so privileged to have been paid for doing work that helps people, for doing good for people. One of the, I don't know if this is the most career satisfaction, but just a cute little story of when one of my kids was going to a little summer week-long day camp called the Bert and Ernie Club, run by the recreation department in Goderich. And you would go for a week, register them for a week at a time. And I think my 4-year-old was going to that. And at the end of the summer, they invited for one day anybody who was who had been there for any of the weeks. They could come on this day. So it was a day that I didn't have clinic hours. So I brought my 4-year-old, and I had the youngest one was a year. So she was sort of on the hip, and I was going to drop the 4-year-old off. And I noticed these poor high school kids running this thing were totally overwhelmed. And there were hot dogs being served, and there were grapes. And I'm thinking, oh my gosh, choking and whatever. So I just stayed and helped. And a little child came up to me and tugged at my pants. And he had been in to see me in the office the day before. And he looked up at me, and I said, "Hi, Josh. Do you know who I am?" And he said, "Yeah." I said, "Yeah, I saw you yesterday, didn't I?" And he looked up at me and he said, "You're a doctor." And I said, "Yes." And he said, "But this is a picnic." And I said, "Yes, but I'm a mom too." And he just stayed glued to me the whole time. It was really cute. So again, those are some of the being able to make a difference and that. And then I suppose the large thing as far as career satisfaction would be the accomplishment of having the Rourke Baby Record kept current and disseminated since it was first published in Canadian Family Physician in 1985. Um, and so to feel that in one small way that may have facilitated excellence for primary care physicians and ultimately improved the health of infants and young children in Canada. But of course, that's something that many people and organizations share in that accomplishment. So it started off with Jim and myself, and then a dedicated core team members. There's been funding from the Ontario government for over 15 years. Various organizations like the College of Family Physicians of Canada, the Canadian Pediatric Society, Dietitians of Canada, Memorial University. So those would probably, I suppose, having seen, if anybody had told me when we first published it that I'd be doing so much, spending so much time in my career on it, I probably would have thought they were crazy. But yeah, I have to feel satisfied that one's been able to have that be steadfast for clinicians and families for almost 40 years. And though maybe in a little way that sort of helps leave things, the world, in a little bit of a better place. So thank you. The SRPC has been an amazing organization, and I've, of course, known about it and been part of it, known about it since before it came about and been part of it. And it has done so much for rural practice in Canada, in all the levels of someone that people could call, colleagues, advocacy, politics, curriculums. I mean, we've known forever that if you want to have people happy and ready to train and be in rural medicine, you have to train them in those settings. And so the education for that and the role that the SRPC has played in that and in lobbying for the resources that often go urban because that's where the policymakers live. And often people go into rural practice to get away from some of that. And that can backfire because you do need people advocating for rural health and rural practice. And the SRPC has been absolutely amazing in taking up all those roles. So big thanks to the SRPC and all those individuals in it.